Hi, I am Dr. Shajil and today I examine this 55 years old male anesthesia technician working in our hospital. He is diabetic and hypertensive for the last 10 years and a history of bypass surgery 2 years back. His vision was 6'9" with early lenticular changes and mild diabetic retinopathy. He came with a complaint of gradual droopiness of the upper lid, left eye, for the last 3 weeks. When I observed him, I thought he is having ischemic Turner palsy. But when I elevated the upper lid, I was expecting down and out eye, but it was in the center. And when I did the extraocular movements, the eye was static in the primary gaze and the pupil was round, regular and reactive. So patient was having external ophthalmoplegia and mild proptosis as well. External ophthalmoplegia means paralysis of the all extraocular muscles, sparing pupillary muscles. Total ophthalmoplegia means frozen globe involving pupil as well. So far it means that the patient was having a healthy optic nerve and oculomotor nerve, abducent nerve and trochlear nerve palsy. Then I checked the cranial nerve 5, corneal sensations were lost, so fifth nerve was also paralyzed, but the facial nerve was all right. He was able to forcefully close the eyes. So I diagnosed him as a case of superior orbital fissure syndrome. It is a collection of symptoms caused by the compression of structures just anterior to the orbital apex. Importantly, optic nerve is spared, which differentiate superior orbital fissure syndrome from orbital apex syndrome, in which optic nerve is also affected. The most common cause of the superior orbital fissure syndrome is trauma, and the other causes are neoplasms like lymphoma and rhabdomyosarcoma, infections like meningitis, then syphilis, sinusitis, herpes zoster, ophthalmicus, then inflammations like sarcoidosis, Tolosa-Hunt syndrome, then vascular carotid cavernous fistula, retrobulbar hematomas, carotid aneurysms, and it can be idiopathic. Risk factor, there is only one risk factor, and that is pre-existing narrow superior orbital fissure. So all structures are passing through the closed space. So infection, inflammation, trauma and tumor all cause mass effect and compress these nerves, and that lead to clinical symptoms. Diagnosis is clinical, like I have clinically diagnosed this patient as a case of superior orbital fissure syndrome. I got external ophthalmoplegia, ptosis, mild proptosis. Mild proptosis is due to loss of the tone of the extraocular muscles, so the globe moves forward, and loss of corneal reflex. Neuroimaging like CT scan with 2 mm fine cuts is done in the cases of history of trauma to look for bony fragments. If no trauma, then MRI is best to look for the masses, and angiography is good for the vascular pathologies. The differential diagnosis, there are two most important differential diagnoses. Orbital apex syndrome, already discussed that cranial nerve 2 is also involved. The next one is cavernous sinus syndrome, in which you will also get Horner syndrome, and all branches of the trigeminal nerve will be affected, and it is a painful condition, whereas in superior orbital fissure syndrome there is no pain. The treatment depends upon etiology. In mild cases, you can just observe the patient. In infections, you can give antimicrobial therapy. In inflammations, megadose IV steroids for 3 days and followed by the 2 weeks oral steroids is given. In tumors and trauma cases, you can go for the surgery as well. So recovery occurs in 20 to 50% of cases and takes up to 6 months for full recovery. Abducens nerve, cranial nerve 6,
shows the best recovery of all the nerves. In few cases, patients needs ptosis and strabismus surgery, but that should be done when no more recovery of the muscles involved is expected. So that was all about the superior orbital fissure syndrome, and I hope you have learned a lot. Thank you.